All right. Good morning, folks. As we still have some folks filtering in and whatnot, we're going to let these slides roll through one last time of just kind of an overview of our webinar today from the Region 7 Disaster Health Response Ecosystem. Today's webinar on the updates of the opioid epidemic. The slides talk about our objectives today, some of the continuing education that we have going on. As well as disclosures for anyone who's associated with our grant. And then there is a slide here that talks about how to obtain your continuing education credits. I'll put some of that information in the chat as we get going. Plus, you should be receiving some follow-up emails either from us at the R7 DHRE or from the continuing ed office here that'll also have all of this information on there. So if you don't catch it the first time, that's okay. We'll have other stuff with that. And I do remind folks that we'll be utilizing the Q&A for this webinar. So if you have any questions, please take care, use that Q&A at the bottom of your screen, and we'll address those at the end. Like I said, welcome to our webinar on the updates of the opioid epidemic, presented today by Krysta Baack. Dr. Krysta Baack is currently the emergency medicine pharmacy supervisor at Nebraska Medicine. Additionally, Krysta is also an intermittent deployment pharmacist for the Administration for Strategic Preparedness and Response, Federal Department of Health and Human Services, and the National Disaster Medical System. Krysta received her Doctor of Pharmacy from Creighton University in Omaha in 2007. She completed a postgraduate year one residency from Nebraska Medicine, also in Omaha, in 2008, and then completed a postgraduate year two residency specializing in emergency medicine at the University of Illinois at Chicago in 2009. Krysta is a board-certified pharmacotherapy specialist and a member of the American Society of Health Systems Pharmacists, American College of Clinical Pharmacy, and the Nebraska Pharmacists Association. And with that, I will let Krysta take over.
Thank you. Are you able to turn on my ability to put my camera on?
Yep, give me just 1 minute here.
Well, while we're getting that started, I'll go ahead and get started. But like we said, my name is Krysta Baack, and I am currently the pharmacy supervisor at Nebraska Medicine for the emergency medicine department. And today I'll be talking to you about some updates within the opioid epidemic. I do have a few disclosures I want to just make sure that you're aware of. One, like I said, I am an employed pharmacist at Nebraska Medicine, as well as through MDMS and DMAT, and I also do serve as a consultant for Pfizer. The objectives today, by the end of the presentation, I hope that you will be able to explain the key aspects of the opioid epidemic, including any recent legislative changes, as well as discuss any state-specific resources for responding to the opioid epidemic, and lastly, identify any signs and symptoms of a xylazine overdose. So as we get started, I just want to make sure we're all on the same page. Opioids are a highly addictive class of drugs used to treat pain. They bind to your opioid receptors that are located both on your central and peripheral nerves, as well as your GI tract to produce analgesia. Opioids can be received through a prescription, or you can get them illicitly, or you can get prescription opioids and buy them illicitly. There are a number of different routes of administration, including oral, injection, both IV and IM, intranasal, inhaled or through smoking, transdermal, and epidurally. The adverse effects include altered mental status, and then respiratory depression or arrest, which is probably what we are most concerned with here today. And that is especially prevalent when used in combination with any other mind-altering agents like alcohol. And then it does slow your GI motility. I thought it would be kind of interesting, and I know when I was putting this presentation together, I kind of liked going back and seeing like the whole evolution of prescription opioids. So between 1911 and the 1990s, opioid pain medications were used primarily for acute pain and cancer pain. There were studies coming out during this time period that were showing inadequate treatment of chronic non-cancer pain, which led to an increased use of opioids. May of 1987, MS Cotton, or the long-acting morphine sulfate, was approved by the FDA. This was the first formulation of an opioid pain medication that allowed for dosing every 12 hours instead of every 4 to 6. Then, several years later, in 1995, OxyContin, or the controlled release oxycodone, was approved. This was the first formulation of oxycodone that allowed for every 12-hour dosing instead of every 4 to 6. This is really considered by a lot of people the turning point of that of the opioid epidemic, was in 1995. Also in 1995, the American Pain Society launched their influential Pain is the Fifth Vital Sign campaign with intent to encourage proper standardized evaluation and treatment of pain. The Veterans Health Administration supported the campaign with their 1999 adoption of Pain is the Fifth Vital Sign initiative, solidifying the national response to pain as the fifth vital sign. The Joint Commission also published their standards for pain management in 2000, which emphasized the need for organizations to conduct a quantitative assessment of pain as recommended by the Institute of Medicine. The Federation of State Medical Boards and the DEA also issued statements at this time promising less regulatory scrutiny over opioid prescribers, thereby kind of appeasing the physician's reluctance to prescribe more liberal amounts of opioid analgesics. In the early 2000s, reports of overdose and death from prescription opioids began to dramatically increase, with OxyContin being the primary issue. The number of people who admitted to using OxyContin for non-medical purposes increased from about 400,000 in 1999 to 1.9 million in 2002, and then to 2.8 million in 2003. By 2009, about 1.2 million ED visits were related to misuse or abuse of pharmaceuticals, which was a greater than 98% increase since 2004, and more than the number of ED visits related to illicit use of heroin and cocaine. The FDA had worked with sponsors for more than a decade to implement some risk management programs and strategies for several opioid products, but these programs essentially were not successful. Then in 2010, OxyContin was reformulated. This reformulated form of OxyContin was intended to prevent the opioid medication from being cut, broken, chewed, crushed, or dissolved to release more medication. The new formulation was only a marginal improvement to lessen the risk of overdose due to tampering, hoping to lead to less abuse by snorting or injection. The new formulation could still be abused or misused by simply ingesting larger doses than are recommended. Then in 2011, the CDC declares overdoses from opioids a quote-unquote epidemic. I think it's also important to recognize and note that between 1987 and currently now in 2024, there have been 31 different opioids or different formulations and or label expansions that the FDA approved during this time period, despite for much of this time period be considered the epidemic. As you probably saw in the previous slide, the opioid epidemic has been occurring since the 1990s and has occurred in 3 distinct waves. The first wave being opioid prescription-related deaths, then another spike in heroin-related deaths, and then what we are currently experiencing right now, the synthetic opioid-related deaths. Overall, drug overdose rose from 2019 to 2022 with almost 108,000 drug overdose deaths reported in 2022. deaths involving synthetic opioids rather than, other than methadone, excuse me, which consists primarily of fentanyl, continue to rise with almost 74,000 overdose deaths reported in 2022. Those involving stimulants, including cocaine or psychostimulants like methamphetamine, also continue to increase with about 27,000 and 34,000 respective deaths in 2022. On this graph here, on the white graph, you'll note that heroin between the late 1990s and currently saw an increase in by 2.5-fold in deaths. Prescription opioids, approximately 4.1-fold increase. Cocaine increased by 7.6. Psychostimulants, with abuse potential like methamphetamine increased 64-fold, and synthetic opioids that don't include methadone increased 103-fold. The overdose crisis has evolved over time and is now largely characterized by deaths involving illicitly manufactured synthetic opioids, including fentanyl, and increasingly now stimulants. One thing I think it's important to note and keep in mind is regarding the different types of opioids, especially as it relates to opioid potency, is how much more potent the synthetic opioids are compared to natural opioids like morphine and heroin. So in this table with the drugs listed on the left, and then that middle number is the morphine equivalent dose conversion factor. So basically how you would kind of figure that out is you would multiply the dose for each opioid by the conversion factor to determine the dose in morphine milligram equivalents. For example, if you take oxycodone here, if you had 2 milligrams of morphine, that would be, or excuse me, if you had 1 milligram of morphine, that would be equivalent to 1.5 milligrams of oxycodone. Fentanyl is 100 times more stronger than morphine, and carfentanil is 10,000 times stronger than morphine. Both fentanyl and carfentanil are synthetic opioids. Differences in potency in the various opioids is an important predictor of overdose-related deaths. About 80% of opioid deaths involve a synthetic opioid, primarily currently is fentanyl. When more than one opioid is involved, the likelihood of death is a lot higher, and many illicit drugs are adulterated, therefore having more than one drug included in them. For example, one may buy heroin but not know it actually has also been adulterated with fentanyl, so you'd be consuming both heroin and fentanyl. The amount or dose of opioid taken, in addition to the route of administration, determines the speed at which the opioid enters the CNS. The pharmacokinetic profile of a drug is determined by the route of administration and individual differences in how one metabolizes the drug. Another important drug property to be aware of is lipophilicity. Highly lipophilic drugs like the synthetic opioids enter the CNS much more rapidly and other lipid-rich tissues compared to drugs that are not highly lipophilic, for example, morphine. Metabolic differences among people due to genetics creates variability in how quickly a drug may be metabolized. There's a greater risk of re-narcotization following rescue with naloxone and drugs with longer half-lives. So essentially, the naloxone has a shorter half-life than some of the opioids, such as methadone and the long-acting or controlled release formulations of opioids. When one uses co-CNS depressants, the risk of lethal overdose increases. Examples include benzodiazepines and alcohol. Polydrug use is very common amongst opioid overdoses, and one study found that approximately 40% of cocaine overdoses, fentanyl was co-ingested, and methamphetamine was also found in about 34% of opioid-related fatalities. There has been an increasing co-use of stimulants with opioids, and some say this is potentially leading to the new fourth wave of the opioid epidemic. Tolerance develops with repeated opioid exposure. Because of this, one may need larger and larger amounts of opioid to achieve the desired euphoric effect. Euphoric tolerance develops a lot faster than respiratory depression tolerance, putting more experienced opioid abusers at a higher risk of death. Some pre-existing medical conditions such as COPD, sleep apnea, obesity, and liver disease can increase the risk of death with opioid utilization. And respiratory depression is the driver of hypoxia and anoxic tissue damage. So the longer it takes between symptom onset and reversal, the more time there is for tissue damage to occur and for respiratory depression to eventually lead to cardiovascular collapse. Opioid-related deaths has a big socioeconomic impact. There was a study that came out in 2021 by Florence and colleagues. They modeled the economic burden of opioid use disorder and fatal opioid overdose and estimated at over $1 trillion in 2017. This estimate includes costs for healthcare, so like hospital, emergency department costs, as well as EMS-related costs, substance abuse treatment, criminal justice, and lost productivity. Most of these costs, estimated at over $549 billion, are actually associated with lost productivity and the value of statistical life lost. Although this is a contemporaneous study, the data do not capture the current economic burden of opioid overdose deaths because of the increase in reported fatal overdoses since 2017 to now. So essentially, that $1 trillion is most likely larger than that here in 2024. So how do we fight the opioid epidemic? Collaboration is probably one of the most important predictors of success. Healthcare personnel, emergency departments, first responders, police, and other public safety health officials and public health officials, as well as members of the community, all bring a different type of awareness and expertise to this situation. Thus, working together, we can better coordinate our efforts and prevent opioid overdoses and opioid-related deaths. The CDC has and continues to provide healthcare providers and healthcare systems with evidence-based recommendations for prescribing opioids and opioid use disorder medications. The CDC also helps to provide states and tribal communities resources and more thorough and accurate real-time data. The CDC helps to recognize the important role law enforcement officials play, thereby ensuring that they have all of the needed tools. Also, it's important to monitor trends to better understand the epidemic to ensure resources are being directed to the most appropriate places and/or persons. The more information the public has, potentially they are better able to make safer choices as it relates to opioids. The areas that we will focus on today include the recommendations for healthcare providers and healthcare systems, as well as state and local resources. Overdose prevention strategies include improved opioid prescribing, prevention of opioid use disorder, treatment of opioid use disorder, and reversing overdoses. So we will now kind of talk about those recommendations for healthcare providers and how we can improve our opioid prescribing. In 2022, the clinical practice guideline for prescribing opioids that's done by the CDC every several years was updated. The last time these guidelines were updated was in 2016. These updated guidelines focus on 4 major areas. And those include determining whether or not to initiate opioids for the treatment of pain, selecting opioids and determining opioid dosages, deciding on duration of initial opioid prescription and conducting follow-up, and lastly, assessing risk and addressing potential harms of opioid use. These guidelines are intended to improve communication between clinicians and patients about the risks and benefits of pain treatment, which may or may not include opioid therapy, improve the effectiveness and safety of pain treatment, mitigate pain, as well as improve function and quality of life for patients that do experience pain, as well as reduce risks associated with opioid pain therapy, including opioid use disorder, overdose, and death. I think it's also important to note that these guidelines do not apply to any sort of sickle cell related pain, nor cancer related pain or palliative care. Clinical areas that these new guidelines, these new updated guidelines include are initiating opioid therapy, continuation of opioid therapy, non-opioid pain management, the treatment of dental pain, opioid use in pregnant patients, and the treatment of opioid use disorder. In focusing on prevention of opioid use disorder, we'll talk about some of the state resources that are available. Recommendation 9 of the guidelines state that clinicians prescribing opioids should first review a patient's history of controlled substance prescriptions using your state's specific PDMP or prescription drug monitoring program. It is the state's responsibility to regulate and enforce prescription drug practices, therefore state laws. Some of the legal strategies that states have used to address this issue include prescription drug time and dosage limit laws for controlled substances. 47 states and the District of Columbia have laws that set time or dosage limits for controlled substances. Within Region 7, Iowa, Kansas, Missouri, and Nebraska all have time limit laws. Each state's laws may differ slightly with what drugs, patient populations, and the hours or day supplies that are limited apply to. 15 states and the District of Columbia, including Kansas and Missouri, set dosage limits based on the type of drug schedule. Iowa, Kansas, Missouri, and Nebraska all have doctor shopping laws that prohibit a patient from knowingly withholding information from the practitioner the patient is currently seeing about controlled controlled substances or prescriptions that they have received from any other healthcare practitioners. Some states have laws that grant either immunity from prosecution or mitigation in prosecution at sentencing for people who call 911 in the case of an overdose emergency. However, no states within Region 7 have these types of laws. Organizations are encouraged to develop quality improvement projects aimed at reducing opioid prescribing. For example, at my institution, in 2019, we changed all of the electronic preset opioid discharge prescriptions for the ED to be less than 50 morphine milligram equivalents per day, which that 50 mark was kind of declared by the CDC as the differentiator between what is a normal-ish amount of opioids and a high amount. Additionally, we've developed prescriber report cards that are used in the ED to show an individual prescriber is in comparison to their peers in regards to their opioid prescribing habits. Many states have safe drug disposal programs. All of the states within Region 7 do. And it's important that people educate themselves with webinars such as these to stay informed to continue to help combat the opioid epidemic. The PDMP was developed to help reduce prescription misuse and diversion and monitor and analyze prescription and dispensing data for controlled substances. The PDMP system includes independent statewide electronic databases that track prescriptions of controlled substances within that state. This data can be utilized to obtain timely information on prescribing practices and patient behaviors. Surprisingly, the idea of the PDMP dates back all the way to 1918 in the state of New York, and then California as the oldest continuously operating PDMP system since 1939. Oklahoma was the first state to establish an electronic PDMP, more similar to what we have today, and that was done in 1991. Despite the PDMP's longstanding history, many states have only recently started to develop and adopt their own PDMPs within the last 20 years. Medication take-back programs are the best way to safely dispose of unused or expired prescription and non-prescription drugs. There are both permanent take-back locations as well as periodic take-back events. All drugs dropped off at one of these locations or events will be securely and properly disposed of. Many times, law enforcement agencies will sponsor take-back programs. For example, the DEA sponsors 2 take-back days a year, each occurring on a Saturday in April and then again in October. Each state has their website, which I do have listed here, and they're hyperlinks if you want me to send out the slides that contain all of the state-specific information regarding where to find a take-back location nearest you. There are other state resources. For example, Stop Overdose Nebraska works to educate the public about life-saving naloxone or Narcan. Stop OD Nebraska is also committed to providing information for resources to get people help that they may want or need. The Missouri Opioid State Targeted Response, or STR, and Missouri State Opioid Response, or SOR, projects are expanding access to integrated prevention, treatment, recovery support, and harm reduction services for individuals with opioid use disorder. The state of Missouri of Mental Health is leading the project with administration, implementation, and evaluation of activities provided by the University of Missouri, St. Louis, Missouri Institute of Mental Health, as well as other health care agencies, academic institutions, and content experts throughout the state. This right here, the DCCCA, is a 501c nonprofit organization with the mission to provide social and community resources that improve the safety and health and well-being of those in that community. While the DCCCA Inc. is the legal name, DCCCA developed a slogan, developing caring communities committed to action, which they feel better describes the work that this organization is doing. This Iowa-based website listed here in that hyperlink provides a lot of different community-based programs and resources to help stakeholders choose, design, and implement their own interventions. It's also designed to help communities develop and launch programs that work across the continuum of care, including prevention, treatment, recovery, and harm reduction. So moving on, we'll talk about the importance of reversing overdoses. So naloxone. Naloxone is the opioid reversal agent. It is a pure opioid antagonist that competes and displaces opioids at the opioid receptor sites. Naloxone is available with prescription or more recently now over the counter. It can be given IV, IM, intranasally, or endotracheal. The onset of action varies slightly by the route of administration. So IV, the onset is around 2 minutes. IM, somewhere between 2 and 5 minutes, which is kind of the same thing for endotracheal. And then intranasal around 3 minutes. Adverse effects of naloxone are all related to opioid withdrawal type symptoms. So patients can become aggressive, become diaphoretic, experience nausea, vomiting, diarrhea, piloerection, and musculoskeletal pain. One thing that's important to remember is that a patient will not experience any adverse effects if you give them naloxone and they are not currently taking any form of opioid. Opioid dosing changes a little bit, again, also dependent upon the route of administration. So the IV dose can range anywhere from 0.04 to 2 milligrams and given every 2 to 3 minutes until you see your desired response. That little tiny 0.04 milligrams is something more that you would probably see in a hospital setting when maybe grandma has like pushed her PCA button one extra time and her breathing is starting to slow. We don't want to fully reverse her because we don't want her to experience pain. potentially from a procedure that she just had. We just want her to breathe a little bit faster. So that's kind of when you'll see those little tiny doses. Whereas when you are concerned with a full reversal being needed, then that will be what necessitates a larger dose. Patients also can receive a continuous infusion of naloxone, and that is for people who've potentially overdosed on really long-acting opioids that the Narcan is just going to continue to wear off of, and you calculate that naloxone dose by whatever the dose, the IV dose that was required to see the reversal effects that you were looking for. You would take that dose and multiply it by 2/3 to receive what your continuous infusion rate. Intranasal dosing ranges anywhere from 2 to 8 milligrams, also given every 2 to 3 minutes. The commercially made intranasal products are a 4 milligram single use nasal spray. So essentially you just use the contents of the entire product to receive that 4 milligram dose. Intramuscular is the same as IV dosing, and then endotracheal, you double your IV dosing. So take 2 to 2.5 times that normal IV dosing listed over here. So that comes to be around 0.8 to 0.5 milligrams. Naloxone was FDA approved in 1971. The first state to implement naloxone access laws was Connecticut in 2003, and the second state was California in 2007. These laws were targeted at increasing patient access to naloxone in the community. While these laws differ significantly from state to state, most contain some or all of the following key features. 1, in the event of a negative outcome, any criminal or civil liability protection for naloxone prescribers, dispensers, or those administering naloxone in good faith. 2, permission to prescribe to third parties, like persons who would likely not be the ones in whom the medication is ultimately administered to. So potentially a friend or a family member that knows somebody who abuses opioids, or potentially like a law enforcement officer that wants to carry naloxone. And that kind of moves on to that allowance for laypersons to possess and distribute naloxone without a prescription, and for mechanisms to enable pharmacists to dispense naloxone without a patient-specific prescription. And that can be done through standing orders in conjunction with a prescriber, or state-level protocols directly granting pharmacists the authority to dispense naloxone without a prescription. Laws vary in the level of immunity that they provide to naloxone prescribers for any acts or omissions performed in good faith related to that prescription of naloxone or eventual administration of naloxone. Currently, 28 states offer immunity from civil liability, criminal liability, and professional disciplinary actions. 5 states in the District of Columbia only provide prescribers with civil and criminal immunity, and 6 only provide prescribers with civil immunity. Additionally, there are 3 states where prescriber immunity is not addressed at all in statute. Like the immunity provided to naloxone prescribers, the level of immunity provided to naloxone dispensers for any acts or admissions performed in good faith related to the dispensing of naloxone or eventual administration of naloxone varies by state. 29 states provide dispensers with immunity from civil, criminal, and professional liability and disciplinary actions. 5 states in the District of Columbia only provide dispensers with civil and criminal immunity, and 5 states provide only civil immunity. There are 4 states that do not address dispenser immunity at all in their statute. Some form of immunity is provided to laypersons who administer naloxone for any acts or omissions performed in good faith related to the administration of naloxone in 48 states, as well as the District of Columbia. 36 states and the District of Columbia provide laypersons with civil and criminal immunity for the good faith administration of naloxone to an individual believed to be experiencing an opioid-related overdose. While associations between naloxone access laws, naloxone accessibility, and reduced opioid-related overdose morbidity and mortality has been observed, overall rates of opioid-related overdose deaths has continued to increase. On March 29th of 2023, so just a little over a year ago, the FDA approved the first over-the-counter naloxone nasal spray under the brand name Narcan, thereby expanding access and availability to the first-line treatment for opioid overdose. And then a day later, on March 30th, the FDA held a large stakeholder call to discuss expanding access to naloxone following the approval of the first OTC naloxone spray. Later in the year, on July 18th, the FDA approved the first generic form of naloxone over-the-counter spray. And then 10 days later, on July 28th, the FDA approved the second branded OTC naloxone spray. In 2021, the CDC said that bystanders were present in approximately 46% of opioid-related fatal overdoses. Having increased availability of naloxone could then, in theory, save lives. The new OTC naloxone products are very simple to use and require little to no education, even amongst non-healthcare providers. Additionally, because it is a single-use nasal spray, a bystander would not necessarily have to do something too outside their comfort zone other than just push the contents of the spray into that person's nose. But I think it's important to note that many people probably feel uncomfortable helping out in a scenario like that. For example, bystander CPR is a good example. People are far more apt to do chest compressions on a stranger than they would be to give any sort of mouth-to-mouth resuscitation, even with a pocket mask. Due to this, the AHA has done a big educational push and for compression-only CPR to promote more people feeling comfortable to start CPR. Because naloxone is now an OTC product, there are currently no age restrictions associated with purchasing it. This could be a pro or a con, depending upon how you want to look at it. In 2022, approximately 15% of all opioid deaths were between the ages of 15 and 24. With no age restriction, teens may feel more comfortable to purchase the product. However, with no age restrictions, one may argue that teens may feel more comfortable abusing opioids because they would have naloxone available without a parent necessarily being aware. Currently, a 2-dose of prescription naloxone is often free to people covered by Medicaid or private insurance, or in some cases costs about less than $10. However, public and private insurance programs do not cover most OTC medications. And I checked right before this presentation at a Walgreens near where I live in Nebraska. The generic naloxone spray is being sold for approximately $35, and the brand name Narcan is being sold for approximately $45. This high cost, and in some areas of the country, the cost is even higher, is a large barrier for most people for buying naloxone. Namely, the people most in need of naloxone will not be able to afford it. Because of that, it increases the likelihood that it will be shoplifted. If that becomes the case, naloxone may be moved behind the pharmacy counter like pseudoephedrine has been. And thus, people will be less apt to buy naloxone if they have to ask someone to get it from behind that counter due to the stigma that still that surrounds opioid abuse. Current naloxone access laws in every state allow pharmacists to dispense the nasal spray to anyone who asks for it, regardless of whether the person has a prescription. But according to a recent report by the Reagan-Udall Foundation, an independent group that analyzes issues facing the FDA, of the almost 17 million naloxone doses that were distributed in 2021, which is a very well-known underestimate, only 2.64 million went through pharmacies. Most doses are given to emergency responders, clinics, and community outreach workers. Previous studies have shown that some pharmacists, especially those working in for independent pharmacies in rural or impoverished areas, do not want to carry naloxone because they do not want to engage with people who use drugs. Because of that stigma, many pharmacists have chosen to not participate in naloxone access programs. Despite the drug being easy to use, there's still an educational gap associated with people's comfort level in buying and/or administering naloxone in the event of emergency. And this citation here, I think, is a really good New York Times article that was published in March of 2023, so right around the time that naloxone went OTC, that discusses some of the issues surrounding naloxone and becoming an OTC product. Attaining a high level of the general population's naloxone readiness requires a series of knowledge, access, and trainings. People ultimately need to know naloxone exists, have access to naloxone, be trained to use naloxone, have previously used naloxone, and carry naloxone regularly for a person to be capable of reversing an opioid overdose. A 2022 study found that there were significant gaps in naloxone knowledge in the state of Nebraska. Almost 75% of survey respondents were familiar with naloxone, however, only 18% knew how to access it and as well as knew how to use it. Being close to a personal overdose experience or a person who uses opioids and having access to illicit opioids were not significantly associated with naloxone familiarity, access, or competency amongst survey respondents from Omaha and Lincoln. Conversely, a higher percentage of community stigma towards people who use heroin, methamphetamine, and cocaine was associated with higher odds of naloxone access. Synthetic opioids now account for most opioid-involved deaths. In 2021, approximately 90% of all fatal opioid-related deaths were due to synthetic opioids. The overdose death rates for fentanyl increased by 279% from 2016 to 2021. Nitazines, or the benzimidazole opioids, are a class of synthetic opioids with non-fentanyl-based chemical structures. Some that have been identified to date include etonanazine, isotonanazine, and flunitazine. In general, the nitazines are about 10 to 40 times stronger than fentanyl. These have never been approved for human use, only veterinary utilization. Because an overdose must be treated as soon as possible to avoid death or CNS damage, it is vital that enough naloxone reaches the opioid receptors as soon as possible in insufficient concentrations to displace the opioid from more than 50% of the receptors. Multiple doses of traditional naloxone products are increasingly being required to treat opioid overdoses, which may suggest that the emergency naloxone, that 4 milligram intranasal product, may be needed to be administered multiple times for rapid reversal of fentanyl overdose at exposure levels capable of causing respiratory depression and death. Nitazines are synthetic opioids, so naloxone should be able to reverse an overdose. However, their high potency means that more and higher doses will be required to reverse its effects. There are some reports of people requiring over 10 milligrams of IV naloxone as a single dose to see any reversal effect whatsoever. The higher potency of fentanyl and fentanyl analogs, such as carfentanil, compared to that of heroin, often requires multiple doses of naloxone, which suggests there is probably a need for higher dose naloxone. So moving on to xylazine. Xylazine is also a veterinary sedative. It is a major adulterant of cocaine, heroin, methamphetamine, and fentanyl. It is available for veterinary use as an analgesic, sedative, and muscle relaxant. On the street, it can be referred to as trank, trank dope, sleep cut, Philly dope, and zombie. Xylazine works similarly as the antihypertensive drug clonidine and the muscle relaxant tizanidine. It acts on the alpha-2 adrenergic receptor sites, causing CNS and respiratory depression, hypotension, hypothermia, and bradycardia, like opioids. Users can develop dependence and withdrawal from xylazine use. Xylazine can be swallowed, inhaled, smoked, snorted, or injected. And the effects typically last for approximately 20 to 50 minutes, but that is also somewhat dose dependent. The sedative effects of xylazine allow those illegally selling and distributing drugs to decrease the amount of opioid in their mixture and yet produce similar effects in the user, making the drug mixture more profitable for traffickers and dealers. However, as xylazine is not an opioid, it is unaffected by naloxone. Routine toxicology screens do not currently detect xylazine. Because it is a veterinary drug, there is limited information about its pharmacokinetics in humans at this time, and how to manage overdoses. This makes overdoses with xylazine particularly scary and difficult to manage. Even with appropriate testing, xylazine may not be detected due to its rapid elimination from the body with a half-life of around 23 to 50 minutes. New xylazine test strips have currently been researched and are commercially available, but they are not being used widespread at this time. Initial findings have indicated that they are valid and of high utility. Overdose signs and symptoms of xylazine include profound sedating effects that depend on the route of administration. They begin to occur around 1 to 2 minutes after use and may continue for up to 8 hours. Signs and symptoms in a patient with suspected xylazine overdose include drowsiness, slowed breathing, lethargy, apnea, dry mouth, hypertension, and tachycardia, then followed by hypotension and bradycardia, hyperglycemia, hypothermia, coma, dysrhythmias, and eventually death. The only available care right now is supportive care, so you need to monitor breathing and airway. If co-ingested with opioids, you can still use naloxone to reverse the effect of the opioid, but again, like I said before, it'll have no effect on the xylazine. And you'll also need to monitor and treat the patient's blood pressure as necessary. One severe complication that we have found related to xylazine is major skin ulceration, ulcers and necrosis. Frequent xylazine use is associated with a higher prevalence of skin problems, including abscesses, ulcers, and infections when compared to incidence of skin infections among people who use drugs that do not include xylazine. Severe infections and necrotic tissue ulcerations among people who repeatedly inject xylazine can appear beyond the site of injection. A 2022 alert released by the FDA warned that healthcare professionals who see patients with severe necrotic skin ulcerations should provide supportive measures and consider screening patients for xylazine use. The mechanism of injury is thought to be related to xylazine's vasoconstricting effects on local blood vessels, which results in decreased skin perfusion. Decreased skin perfusion further leads to impaired healing of wounds and increased risk of superinfection. When coupled with repeated trauma of injection, xylazine can then lead to extensive ulcerization. This picture here is from a case report that was published in 2024 of a 43-year-old lady who was known to be an opioid abuser, who then later found out she was also abusing xylazine. This 1A and 1B pictures were her initial clinic visit. The wounds were washed and she was given a course of doxycycline. 7 weeks later, she represented to the same clinic with looking like these pictures here on the 2A and 2B side, stating that she had completed the course of antibiotics, but it had gotten worse. At this clinic visit, again, her wounds were washed, dressed, and then she was given a prescription for sulfamethoxazole trimethoprim. However, we don't know whether or not that fully treated the infection with the second visit because she was lost to follow-up. There are currently no clinical practice guidelines for the treatment of xylazine-induced skin wounds. With seeing an increased prevalence of xylazine-adulterated drugs in the US, guidelines and more readily available testing methods are probably still needed. The first known illicit use of xylazine was reported in 2001 in Puerto Rico. It was used in a polydrug combination called a speedball that included a stimulant like cocaine or an amphetamine and an opioid with like heroin, morphine, or fentanyl, and then obviously the xylazine. From there, xylazine was found sporadically in drug samples from around the United States between 2006 and 2018. Philadelphia, Pennsylvania, and Connecticut appear to be the epicenters for xylazine within the US. Adulterated illicit drugs containing xylazine has been increasing exponentially. In 2021, xylazine was found in greater than 90% of all illicit drug samples in Philadelphia. The full national extent of the problem is still unknown. However, the percentage of all overdose deaths in Philadelphia involving xylazine has increased from 2% in 2015 to 26% in 2020. Xylazine was also linked to 19% of all overdose deaths in Maryland in 2021. Overdose deaths involving xylazine have been spreading westward across the United States, and as of July 2023, xylazine has been detected in 48 of the 50 states. Due to the increasing presence of drugs adulterated with xylazine and its negative effect on the opioid crisis, xylazine has been declared as an emerging threat by the White House's Office of National Drug Control Policy. On April 12, 2023, the White House published an address calling for a national response plan to tackle this issue, specifically regarding fentanyl adulterated with xylazine. In the White House's address, it stated that by declaring xylazine combined with fentanyl as an emerging threat, we are being proactive in our approach to save lives and creating new tools and for the public health and public safety officials, as well as communities across the nation. As part of its national response, the White House office developed an intra-agency work group to develop the national response plan. On July 11th of 2023, this office published its national response plan, which called to coordinate a whole government response. This call for action included the DEA and the Department of Homeland Security. On September 22nd of 23, the DEA and DHS provided an update on illicit use of xylazine. The two agencies have found that xylazine intended for human use is entering the U.S. in solid form from China and other countries. In liquid form, it is entering the U.S. through diversion from veterinary supply chains, being repackaged to look like the veterinary drug. Lastly, there's been a smaller amount of xylazine seized on the southwest border that has already been mixed with fentanyl. The National Response Plan has included 6 pillars of action, including testing, data collection, evidence-based prevention, harm reduction and treatment, and supply reduction, as well as scheduling and research. The goal is to end fentanyl xylazine emerging threat by reducing the number of xylazine-related deaths by 15% in 2025. We need increased community awareness of xylazine presence and risks and known risk associated with its use. Additionally, education around xylazine use and overdose risks is needed in hospitals, emergency departments, and clinics. Like I said before, there are still no guidelines to help guide healthcare professionals on the treatment of xylazine overdose, nor guidelines on the management of the complications surrounding its use, specifically for wound care. Lastly, widely available testing within the local toxicology labs, as well as point-of-care testing, is still needed. A summary listed there, and due to time, I will be probably able to answer 1 or 2 questions.
Fantastic. I do want to remind folks, if you have some questions, go ahead and pop those in the Q&A here. One of the questions I guess I thought about while you were speaking is you mentioned, sorry, I wrote it down here, things like the drug takebacks, and that as far as, correct me if I'm wrong here, as far as state-sponsored ones, they do those like twice a year. I guess the other question would be, if someone finds themselves at a point outside of those specific ones, what other options for safely disposing of spare or leftover opioids or anything like that?
Yeah, so in the state of Nebraska, it is Take Back Day every day. So there are a number of different participating pharmacies in the program that are listed on that website that you can go to, or if you just Google like take back programs in your state, most states have quite a few permanent take back locations, which are typically at a pharmacy that you can take your drugs that you want to expose of or dispose of there.
Okay, perfect. And then I guess I was wondering, this one's more for me and everything. I know that for things like people who have substance abuse issues and things like that, do you feel like there's a reluctance for uh, some of the treatments options, such as like I'm going to say it wrong, the buprenorphine or anything like that? Seems like maybe there's I don't know, just some sort of a reluctance to utilize that as a tool to help people, or
Yes.
thoughts on that?
So for a long period of time, you had to have a special DEA license to prescribe a drug like methadone or Suboxone, as well as a pharmacy able to dispense it. So I think there might be reluctance right now just because of the long-standing DEA restrictions surrounding it, but some of those restrictions are starting to change state by state. And so they are allowing for a little bit more liberal prescribing of it, but prescribers that are going to prescribe it still have to go through an educational course in order to do
Mhm.
so. I think it's a quick online course that you can take if you're wanting to prescribe it outside of that emergency 72-hour supply. So I think that's probably where a lot of that reluctance or hesitation may come from, is just from a historical restrictions.
Okay. And then there is a question that came in here asking, is there any written information on xylazine education that, as public health, they can use in community education events?
So when I was doing my research for this presentation, I think maybe one of the better things to utilize is a HON or a health advisory notice, which typically gets sent out by your local poison control centers. So I know Nebraska has they released a HON, I believe, last summer regarding xylazine, and it has really good information that is written at a level a non-healthcare professional would be able to understand.
Is there anything, I guess I'm wondering if they're thinking more in terms of um, just to the general public, because I know a lot of the public's not going to necessarily know what a Han is or anything like that, but if just any kind of a campaign around just
So
awareness or
yeah, so
anything like that.
I typically the CDC is the one that kind of pushes out that big educational surrounding drugs, and I have not seen anything come from the CDC yet or any other agencies at this point in time that is being used as a public campaign. But given that White House address last summer and then that committee that they developed, I would imagine that that's probably forthcoming.
Mhm. Okay. Um, All right, I do see it is the top of the hour. So if folks have to jump off, we thank you very much for coming and attending today. There is some information in the chat there about how to get your continuing education credits. Also, you'll be receiving some follow-up emails on that. There's always the inevitable question of, can we get the slides to the presentation? I leave that to you, Krysta, for if we want to share those out or anything. If they want to get a hold of you or get a hold of me, we can go either route with that.
Yeah, I'm happy to share.
Okay. And then I do see there was one person, because we have a whole bunch of people jumping off here. Looks like Ann Boley had her hand raised. I guess, Ann, did you make it so that you can talk real quick here? Did you still have a question, Ann, or was there? I guess I don't know. I don't see anything with that just yet. If you do have other questions that we didn't get to or anything like that, feel free to reach out and let us know. I'm gonna put the Region 7 email address right here in the chat right quick if anybody has questions that they didn't get to. Otherwise, we thank you all for coming and attending today. We thank Krysta for talking about this rather alarming topic that keeps kind of reinventing itself.
Thank you
And we
all.
hope, yep, and we hope you all have a great rest of your day.